Well, good morning, everybody. This is just, on a beautiful Saturday morning, this is just such a terrific turnout. And the Cancer Center has just had a really glorious week, and we're going to have a terrific day and a terrific evening. So I really thank you for being here. And what I'm going to do is update you and orient you to the things going on in our Cancer Center and your Cancer Center and what our plans are for the future. And the singular plan is to grow this center for an NCI designation. And for those of you who are with us, we were visited by Dr. James DeRochelle, who's actually a colleague I've known for many years at City of Hope, and now one of the highest-ranking doctors or physicians in the National Cancer Institute Center for Treatment and Diagnosis. He joined NCI in 2004, and he was really impressed with where we're going and where we're headed. And at the end of the week, and that, of course, Dr. DeRochelle was the inaugural Hardesty lecture speaker. Couldn't have been a more perfect match for Susan and David as well. And then Friday, Dr. Kevin Cullen joined us, and that's significant because the University of Maryland is one of the newest NCI centers, and they've just achieved an NCI designation. And he, too, was impressed with how we're going. And at the end of his talk, we asked him to give a little synopsis of what it requires to be an NCI center. And a couple of my colleagues are beginning, I think, we're all starting to connect the dots, and I'm going to share some of that with you. They're not too far ahead of us. And for a center our size, who we are and what we are, we're growing and we're headed in the right direction. I have said since day one that we arrived on campus here back in July 2007 that the greatest success will be how effectively we partner. That's how science is done, collaboration, partnerships. That's how NCI is funding grants. So anything and everything we do is a manifestation of how well we reach out and can partner with folks. And you're going to see the things who we're partnering with. Also from day one, these are the guiding principles that we have outlined. They're not necessarily prioritized, but we've highlighted teamwork, quality, innovation, teamwork, service, accountability. And the best thing that can be said about any NCI designated center, the whole is greater than the sum of its parts. And when I looked at this institution, that's perhaps one of our biggest strategic advantages. The whole is greater than the sum of its parts. That's easy to achieve at this institution. I'm going to come back to this slide at the very end, but why seek an NCI designation? Enhanced patient care and clinical reputation, commitment to a cancer service line, and we're working with hospital leadership to try and reinforce that notion across everything. It's not a cancer center, it's a cancer service line. If we think service line, you engage nurses, you engage the orthopedic surgeon who does sarcoma surgery, you engage the GYN surgeon who does oncologic surgery. You engage pediatrics. Think service line, nursing, everything we do, social work. It's a good way to think about organizing a medical center, and that's how we're trying to integrate the Cancer Center into this institution. There's obviously political and legislative leads and impact with an NCI designation. If you're not convinced of that, a colleague, you'll see on another slide, Emory University just achieved an NCI designation, University of South Carolina, Stanford, Maryland, and Baylor. And there are national press stories. Our folks we're working with in the School of Journalism sent me an article. I haven't gotten it. He sent me a hard copy. Emory, in a big city as Atlanta, talked about the economic impact of an NCI designation for Emory University in Atlanta. It is huge. Don't underestimate that. And it raises the bar on so many other things at an institution. Provides new opportunities for philanthropy, economic value, Cancer Center value add, overall contributes to the overall mission of the Health Sciences Center, School of Medicine, and the university, plus the added advantage of enhanced academic reputation. And I've said this many times, our getting an NCI designation is the equivalent of an academic Fiesta Bowl. So I won't say Meineke Card Bowl, but I'm going to say academic Fiesta Bowl, right? You get the picture. Our strategic principles address the cancer health disparities in this state. That's another thing that's unique for us that we can champion and take advantage of to get us to a grant quicker. Very easy to achieve here. That was another attraction for coming. Establish effective partnerships, as you've seen. I'm going to go through all those slides. And I told my colleagues, let's work hard and have fun. Again, overall whole is greater than the sum of its parts. These are the bullets. You've heard these at different venues throughout the week. This state has the 4th highest cancer mortality rate in the country. The 4th highest. Cancer incidence is not necessarily higher across the board, but mortality is, and that tells you a lot of different things. Access, advanced disease at time of diagnosis. This has the 2nd highest cigarette smoking consumption in the country. Depending on whose scorecard, the 2nd or 3rd highest obesity rate in the country. The oldest median age in the country. This state has a median age of 38.9 years. Guess what? Cancer is a disease of aging. HPV infection, human papillomavirus infection, a very common virus, has the highest prevalence in this state in all of Appalachia. See, it's reflected in increased incidence of head and neck cancer, GYN malignancy, cervical cancer. This state has amongst the highest incidence of cervical cancer. And we need to grow our GYN and radiation therapy programs to address that problem. And then you have the socioeconomic disadvantage. And another thing that was very attractive when you look at it, because this is a small state, and a lot of things in this state are cataloged. And I'll give you a very nice example. 325 patients die a year in this state from breast cancer. There's not a place in the country where we can park Bonnie's bus and in 5 or 6 years have some data to begin to see some trends, hopefully decline in breast cancer with a denominator that is that well defined. I couldn't do that in New York. We couldn't do that in Atlanta or wherever. Very unique opportunity. And we'll take credit for the decline with Bonnie's bus, and who's going to dispute it, right? The denominators in this state are cataloged for so many different diseases, not just cancer. And that is a unique advantage to take advantage to grow any kind of NIH platform. And we're keenly aware of that in the Cancer Center. I'm not going to go through each one of these people, but when we got here, this Cancer Center has reached out to all entities on this campus. That's the fun part of being at a Cancer Center. And the grant, actually, that we want to write will go through the university. And there are so many areas of expertise outside the Health Sciences Center that we can take advantage of, and we are taking advantage of. And you'll see the people that we are meeting and have met. And on this campus, we have wonderful relationships with Dean Narsavage in the School of Nursing, Pat Chase, the Dean of the School of Pharmacy, and Richard Kraut, and we're working with the School of Dentistry on projects as well. But we've established relationships with all the entities on this campus up here, and we're working with entities on the undergraduate campus, as summarized here. We're taking advantage of the RHEP network, tapping into that as a state resource. We have worked with the foundation on development opportunities, and specifically the West Virginia Research Trust Fund that I'm going to talk to you about, our board, the hospital board, our immediate board on our cancer center, the university board. NIOSH is right across the street. We must take advantage of NIOSH when we write a grant. If we're getting a federal grant from the NCI or NIH and we have another federal institution right next to us parked on our campus, we must figure out ways to collaborate, and we're doing that. That also provides value add, and it shows us, it'll show the federal NIH folks that we're making an investment to reach out to other federally funded agencies to collaborate. It is very, very important. The provost office in Bucks for Brains we'll come back to in addition to the foundation. We've met with Dean Mazie. Last summer I was on vacation. I got a call from a faculty recruit, came from Penn, has a K25 award, computational biology of a VEGF receptor. That's a fancy receptor on cancer cells, looking at the density of this receptor, and they needed help to figure out how to integrate him into the cancer center. It was a slam dunk. He's in the Department of Statistics on the Eberly College. We're working with the School of Business. We have met with them. We want Tom Witt to do an economic analysis starting now so we have a good denominator so we can do an economic analysis of the impact of our grants in this cancer center. And fortuitously, because of the Stimulus Recovery Act, we're going to write a CO6 grant. And one of the criteria, 2 criteria for that grant economic opportunity, green technology. We're going to be able to show economic impact of the shell space that we have to fill out, the new hires, the new scientists, the new R1 grants that we bring in, the new staff, the new nurses, and champion the green technologies that we need to develop. And we have a geographic edge. And we already have shell space. It's shovel-ready. You've read that in the press, shovel-ready. So to fill out that extra space is shovel-ready. We'll be writing a grant in the next couple months. We've already worked with Fred and his office and Wendy King and all the engineers on the hospital side and the Health Sciences Center. This is a grant I love to write. I only have to come up with 3 pages. Fred's shop has to come up, and Tom and Bruce McClymon's shop has to come up with 18 pages of engineering and architectural plans. It's a slam dunk for me. I can't pass that one up, right? So you'll see all the different people that we're working with. And what is the most remarkable one, I should say, we hired the capstone class of the School of Journalism that is going to come out with an advertising campaign for us. The best investment of the Cancer Center, we paid $7,000. They ended up contracting with the top 3 or 4 healthcare PR firms in Washington, D.C. and Repass. We have 250 patients that have been, or not general residents of West Virginia zip codes, asking them about trials. We've canvassed physicians. In the meantime, we're working with James Shumway to write an R25 cancer grant, and what we're learning from these things, residents in West Virginia want to know about clinical trials. They tell us in this survey that we paid that we're going to use as preliminary data in our grant, we don't know about trials. Tell us more. Not a guarantee they'll participate. The preliminary data from the physician side is we're too busy. We think trials are going to threaten patients. It's too fearful for them. And the good news, James and Debbie Falcone this week for our patient stories, I don't know if anyone heard it, but 1 of the 5 patients that we presented was on a clinical trial. The national average for participation on an adult clinical trial is 3%. We want to strive for 10, 15%. We can do it. We have to educate people. And another striking thing, before we wrote the grant, we did a survey, because this educational grant, our hypothesis is we want to move it into students. And we have a hypothesis, even for a survey or an education grant. So the preliminary survey, we asked about 10 questions, just fundamental knowledge about trials, and then another 10 or 15 questions about what is your awareness of trials and the importance in your practice. We've sent this as an electronic survey to the dental school, the nursing school, the medical school, and the pharmacy school. And we purposely selected the first-year class and the fourth-year class. And our preliminary data, again, this will be in our grant. First-year students across the health science campus, they're thrilled. This is great. We need to know about trials. Guess what happens? Fourth year. Boom. Wonderful opportunity for us. Let's move the education forward into the healthcare curriculum on this campus. I think we'll have a competitive grant, but we have a lot of preliminary data that we're going to be writing that nobody else has, and we're going to see how that resonates. But first rule of grant writing is you can't get a grant unless you write the grant. Can't get funded. My second rule is if you're going to write a grant, you should write 2 grants, because it's not too hard to repackage it to get your second grant. And the third grant, which is another reason we came here, is whenever you can write a grant, you want to slice the denominator. So if the denominator can be cut, you do not pass up that opportunity. And a nice example is what Laura Gibson has done with the COBRA grant, because we have a supplement. Only people that have COBRA grants can write supplements, and we've just sent 2 or 3 supplements, I think, in with the COBRA grant that had to go in this past week. Slice the denominator. These are all grantsmanship things, and we can take advantage of these things strategically at an institution like West Virginia. We don't have to compete with the Harvards or MD Andersons. You get it. So here are the folks we've met throughout the state. I won't go over them in great detail, but in less than a year, we've reached out to the oncologists throughout the state. We've formally set up an oncology society. Here's the other collaborators in the region and the state. We talked a little bit about NIOSH. Now, these are the CCSG. This is what we want to write, Cancer Center Support Grant. It's a P30 grant. These are the essential characteristics. This is what goes in our grant application. We have to write pages on each of these things. And for an institution our size, not only the Cancer Center, you have the commitment of the expansion of the Blanchard Rockefeller Institute, the Irma Bird facility, new research building, and the Cancer Center. It's unprecedented growth on this campus, and we can take advantage of that, plus the new facilities that we have in the Cancer Center. Organizational capabilities. Dean Brick, Bruce McClymans, Fred Butcher, and Tom Jones are committed and have been committed, and we're moving forward with growing this Cancer Center. So there is clear documentation of institutional commitment, and that's reflected in the new facilities. And another thing that you will see as well, as we talk about institutional commitment, is philanthropy. We put in charts of the endowed chairs, the endowed professorships, the funding that was given. Because the institution, you say, well, that's from a donor. Yes, it's from a donor. But the institution has directed that to the Cancer Center. And for an institution our size, the philanthropic impact on this size Cancer Center is absolutely enormous. We're going to come back to that in terms of the other things that we have to do. The third bullet is what we're going to have to work on the most. I've worked on this with my colleagues, and I think after the 18 months we're here, people are beginning to connect the dots. We have to co-publish. We have to write co-PI grants. We have to interact. It's no longer acceptable to write a paper and not have just one author in one program. Multiple authors from the same program or different programs. That's the hardest piece. Dr. Droshow said it's not the amount of funding. It's the substantiation, the documentation of the interactions that are facilitated by a Cancer Center grant that shows interdisciplinary, cross-disciplinary research activity. And Center Director, the one thing I assure you, I took the bullets out of the NCI guide and wrote my proposal to this institution aligned with the requirements that the Cancer Center Director must have the authority over. So I stand before you today. What has been written is still being honored, and more importantly, it's set up that why I got here, of all the things we worked on, this was the most important to me. And I realize we don't have unlimited resources. But the investment in the Cancer Center Director is very, very important for an institution to get through an NCI grant process. Very, very important review criteria. And we've addressed that quite nicely. Cancer focus might sound kind of funny, and I'll come back to that. These are the essential characteristics. This is the body of your organizational background in cancer and focus that you put in a grant, and it's the whole beginning part of your grant. And we can address just about every one of those right now. These are the programs. You have to have scientific programs, a minimum of 3. I won't go through this in great detail, but at the bottom line, minimum of 3 programs, $4 million of research funding, but you have to connect the dots and show the interactions and the value add. Shared resources. What do they provide? They provide and enable science and collaborations, the technologies that you've seen as you've gone through, the different donors that have provided us additional support. Must be shared and must enable scientific collaborations. Here's the types of grants. This gets you to cancer focus. So it's not only the amount of money you have, but it's the type of money you have. And these are the funding agencies that count towards CCSG eligibility. And what I've done here is I've highlighted the Komen grant, because the Komen grant that we wrote for Bonnie's Bus was a nationally peer-reviewed grant. And if we had an NCI grant today, that funding would count on the bottom line. And then when we talk about cancer focus, beyond this list of grants, you take a percentage of how much is actual NCI funding of your pool. That's what really drives home cancer focus for a review committee. NCI wants to see the amount of money they're putting into this institution to substantiate cancer focus. So our funding target, they're mechanics. The most a new center can go in for is $1 million. You make a decision where you go in for a 3-year grant or a 5-year grant. And then there's a fudge factor. You're allowed to take 15% of your total CCSG funding base to get to $1 million. So the most you're allowed to put in as a new center is $1 million. You take 15 times 15%, you got to get to $6 to $7 million. We will not be competitive if we just go in at the bottom $4 million. So our target needs to be about 6, 7, $8 million to really secure our first opportunity of getting a grant. Won't go into this great detail. We're really in the process now. We're building up some capacity. We're going to do a complete overview of membership, invite everyone on this campus to apply to the Cancer Center. But currently, this is how we're structured. It's going to be a lot different by the time we get to a core grant application. About 120 members, 12 departments, 21 departments, 7 schools are represented as best we know right now on this campus. Turning our attention to science, these were the topics that we had at our scientific symposium the other day. Every one of these projects, peer-reviewed, NCI-funded, Department of Defense funded, CDC, cutting edge, some basic to actually population, summarized here. And you see the funding, you see our presenters. And this is an example of a new R01 grant. You've heard this before, Ray Railman's PEMPET, positron emission mammography machine. It's the prototype that's been developed nationally. Just got a new R01 grant that's going to support the clinical testing of this. We're very excited. One of the things, that, again, that excited me about here, oftentimes the hardest piece to put together in a cancer center. I was on the University of Chicago site visit the year after I got here in the fall. They substantiate $800 million of institutional support. They were one of the first NCI-designated centers, but they were never a comprehensive center. And the piece they were missing was population prevention, cancer control. We have an enormous cancer control population tobacco research program, and that's substantiated by this NOT program that was celebrated this past year through 20 years. What is it, 20 years of the PRC? This is the first community-based participatory research intervention that has grown out of 20 years of funding by the CDC, Centers for Disease Control, that has evidence behind it as an effective means to prevent or help diminish teenage smoking with about a 15 to 20% quit rate. And this program has been on the website at CDC. It's listed on the NIH. It's adapted by the American Lung Association. And what's even more cool, it has a WVU signature. This was developed here by Jerry Adino and Kim Horn in the Tobacco Research Program and the Prevention Research Program. Here's our funding sources. We have about a $23 million total budget. If you drop, we have about a $15 million budget in peer-reviewed funding or federal grants, foundation grants. And what I'm doing is if you look at this budget, I'm going to show you another table. This is very powerful. And this gets picked up on an NCI site visit. If you looked at our endowed professors and chairs support that we're going to announce tonight, some new developments, we have $5.2 million of endowed professor support. That represents almost a quarter of our budget. And for an institution this size, in this state, that will mean so much when we write a grant. That will get us to a grant quicker. That speaks to institutional commitment. It's very, very important. Does not get underestimated when you write a grant. This slide is even more what we've done. So we have all sorts of spreadsheets, how we have to look at our funding. And my poor administrator ruptured his appendix, so we couldn't get some of these things updated. And we have some grants on the line. So this is as of January 2009. And as I speak to you, there are about 3 or 4 new R01 grants that have just got funded that we've heard about. Ray Railman, Binghua Zhang, Zhu, and Ray Railman. We have 3 grants and a supplement. So we are close to $3 million. So in about 18 months, we have grown our research base by more than $1 million. This is a nice pace. This is a very nice pace. So as we sit here today, we have about $3 million of peer-reviewed CCSG-eligible funding. Now look at the bottom on that slide. Remember I said cancer focus? For an institution our size, if you take that $2.5 million, 50% of that is NCI funding. Most institutions, 10 to 20%. 20% is outstanding. So if we keep doing that, and that is a reflection, it is so much easier, and that's a credit to Fred Butcher and Eddie Reed, we have a nice and excellent foundation in basic science. And it is the best way to build your cancer center. I'm a clinician. We have credible basic science. And this is a reflection of a lot of the basic science research in this cancer center. That is a phenomenal ratio. And that's what we need to grow. And when we looked at this opportunity, we were figuring we probably need about 20, 25 R01s. I'm thinking we already had about a third. We're going to grow a third, and we're going to buy a third. That's kind of how I put this together. We put it together in our heads. We're on pace, but we can pick it up, but this is just extraordinary. So we're growing our research base. These next two slides, again, remember I showed you the summary of the $5 million. These are the endowed chairs and distinguished professorships in the cancer, going back to the Mylan Chair, which is one of the first. It's not a cancer center endowment, but it presently is held by a cancer center investigator, and that's Bill Petros, who's here in front. Then you have the DeLynn Chair that I have the pleasure of holding. And then what Joe and Ben Statler have enabled is just really extraordinary, because not only is it the $2.5 million, it also matched to an eminent scholar positions of an additional $2.5 million. And we're also going to announce, which is the most important thing in this economic times that we have the opportunity to take advantage of, is the West Virginia Legislature Research Trust Fund. So there was an old account in the cancer center that an estate came through, Alexander B. Osborne, and we tried to dig up a picture. If you saw his by the Pheresis Center, his estate delivered $630,000. We had the equivalent of close to $1 million for a distinguished professorship. And we worked with the foundation to see if this would qualify as a match. And it does. And it did. So now we have a distinguished professor that's endowed, and we are endowing a hematological malignancies program like the Allens did for the lung cancer program. Very, very powerful. So now we have access to $1.57 million of endowed support to build. Huge, huge. And these are the philanthropists that have set up programs or other things in our institution. And again, for an institution this size, this is extraordinary support. The Pushkar Breast Center, the Sarah Krill Allen and James Frederick Allen, we talked the comprehensive lung program, the mammography program. You saw the poster about the Richards Estate to help buy core facilities. That was the endowment that we set up the Hardesty Lecture in the Cancer Center. The Research Trust Fund has matched now the Alexander B. Osborne program in hematological malignancies. We're going to be reorganizing that. And then the CREST Fellowship that we've just gotten through that might be eligible for postgraduate training. And I think this does qualify for the match, right, Will and Julia? So here's another opportunity where a $300,000 gift becomes $600,000. Wonderful opportunities for us to take advantage of. I'm going to show you two slides, and this is why we need to do trials. This was a patient of mine who was featured in U.S. News and World Report when I was in Cleveland. He had anaplastic thyroid cancer, which is perhaps the most lethal solid tumor you can have. He found out about our trial in Cleveland before the trial was even up back in 1999, 97, he went on study through the internet to get on a phase 1 study. And don't ask me how, but that's the power of trials. He got cured of his disease. Unbelievable. So after he had big neck mass here, extended into his mediastinum, was growing through radiation and chemo. His wife came to me. They saw me 2 months before the trial was ready. We already started a queue. I said, how'd you find out about it? Because we hadn't advertised the trial yet. He said, well, we went on the internet. We looked for new drugs. We found Oxygene. We did this. We did that. And there they are in clinic. Start him on the drug therapy. After his first cycle, he tells me, I'm moving my neck better. I never was able to do that. Mass was absolutely much smaller. I was shocked because he was like the 8th patient ever treated with a drug. After 8 cycles, everything had normalized in his chest. And I worked with our ENT group, said, this is ridiculous. I don't know what to do here. We presented them to our interdisciplinary tumor board with head and neck folks. I said, let's go in and do surgery and see if there's anything left, because then we might want to do something. It's a little unconventional. The surgeon said, yes, let's take a look. They went in. It was mush, nothing, no evidence of tumor. Then employing traditional chemotherapy principles, we gave 2 more cycles beyond a complete response. He finished that in October 1999. He's free of disease ever since. He's a poster boy for anaplastic thyroid cancer. And this has provided us an opportunity for an orphan disease, rare disease, to do other drug trials that we've been involved in. We're leading one here with Cambretastatin, an international trial. We've had some patients come from all over Canada, Florida, and I forget where else we had one. We've only had 1 other centers are up and running. Have some other trials. It's a rare, rare disease. But you begin to see the impact of the internet, our electronic world, and where we're heading, where patients get information. And I won't go into this story much later, but here's a lady that relapsed with multiple myeloma who was treated on a phase 1 study as well. And when I left Cleveland, she was on 80 cycles of therapy, free of progression, with multiple myeloma following a transplant. This is the power of trials, trying to provide new answers, new drugs. They're not for everybody, but it's what this cancer center has to be about to really grow. And that's the biggest challenge we have here. And I think that was part of the attraction for the institutional leadership, since I'm more clinically oriented and translationally oriented, to build that aspect of the program, because we have outstanding basic science, we have good population science. The future of cancer care is summarized here. We really need to grow our surgical enterprise. It is the entree to a cancer center. Same for radiation oncology. And we're growing the cancer center despite some challenges in surgery and radiation. Those are huge challenges for us. But the good news is, and Dr. Cullen from Maryland said that, and I wish everybody in the room was, we had some folks from medicine. We don't get graded on radiation and surgery. That's the good news. And I knew that coming here. We get graded on science, interactions, and we have 2 programs in the cancer center that are almost as good as anywhere. Breast cancer, hematological malignancies. Those are going to be our centerpiece clinical translational programs. So we'll cover the clinical. And no doubt they're the portfolio, the bulk of our clinical trials portfolio. Minimally invasive surgery, robotic surgery, targeted therapies. The hospital, Bruce McClymonds, we're currently in the midst of looking at a major investment in upgrades and technology that we do need to build up radiation oncology. We do have some options for attracting physicians, and we're working with Tom Jones and the health system to try to figure this out, to really build this part of our cancer care spectrum, if you will. And the pieces that you've not seen, before I got here, all this was planned out, and it's a credit to Dr. Abraham, Deb Falcone, and Kathleen Murphy. In the old space where we are, we're renovating, where we're going to have 4 multidisciplinary pods, where we hope to have one-stop shopping. So the GYN oncologist, the medical oncologist, the nurse, the radiation therapist, the breast program, all the doctors can be with James in this one room where we run all this clinic out, so the patient doesn't have to go. MD Anderson, all the big Memorial Sloan Kettering, they all have one-stop shopping. We can't do that for every disease. We're going to pick the ones that we're really good at. And breast, heme malignancies, GYN, sarcomas, head and neck, lung, those are the ones that look to be the most formative to begin to develop these multidisciplinary type teams and build the concept of one-stop shopping. Therapy is getting more and more outpatient. Therapy is becoming more pills. Therapy is not that makes your hair fall out. Blood counts go down. So there's a big shift in cancer care from intensive inpatient to outpatient. And the institution is preparing for that. Many types of cancers are becoming chronic diseases, much less reliance on inpatient stay. Access to coordinated care. Outpatient care will be at a premium. That's why this space is so wonderful. One of the places we couldn't show you really is where we need to grow a clinical trials research unit. There is no place on this campus as a academic health sciences center to hang an investigational drug. And that's important because you cannot ask for the same reimbursement if you're hanging an investigational research drug. So this grant we talked to you about, the CO6 grant, we want to use to help see if we can compete for funding to fill that out. Be a huge asset and resource for this campus and the cancer center. And another part is to align our cancer care with our patient populations. We've told you that, the cancer disparity. So we're going to grow breast, we're going to grow lung, we're going to grow ENT, we're going to grow GYN. We have the best bone marrow transplant program in the state and one of the best in the country, having rounded on. It's a tight group. You're going to hear a little more about that. We cannot do everything, and that's okay. But we're going to figure out the 3 or 4 things that we do as well as anybody. And we're working on that. So here's our trials. These numbers are not robust, but there's some very key indicators that are very important. If you look at 2006, we had 45 patients. The next year, we saw a 50% increase in accrual. And what's even more remarkable about the increase in therapeutic accrual is that that has occurred despite no growth in clinical faculty, in fact, attrition of clinical faculty. And the mantra is that every patient that comes into our cancer center must be considered eligible for a clinical trial. And the next thing on that slide is we now have 4 investigator-initiated studies, whereas we only had 1. And those are the thyroid cancer. We have a wonderful investigator-initiated IND study that Bill Petros is leading, that he wrote the application to the FDA. We've just launched an umbilical cord blood program. And Dr. Al-Taha is going to be leading a refractory glioma study with Avastin, bevacizumab, monoclonal antibody, and cumbretastatin. This is the lifeblood of a cancer center that gets integrated into your core grant application. And the other thing, this non-therapeutic accrual is going to blossom. And non-therapeutic accrual is going to be in the thousands at this institution. Remember that survey I told you? The medical students and dental students and nursing students? Well, we have now set up our trials operation to be consistent with CCSG guidelines. So we might have interviewed, I don't know, 600. Do you know how many I don't know how many we've gotten through. James not here. But let's just say for the sake of discussion, we got surveys from 600 medical students, nursing students, dental students, pharmacy students. We haven't registered in our database, but that protocol went through our protocol review and monitoring committee, which the NCI guidelines say you have to have. And because we have data, each one of those people becomes a data point. So by the time we write our CCSG grant, we might have, I want to see if we can grow here, maybe 150. Now you see the reason why we need to have a trials network. To get 200, 300, that's a credible number. But we're going to see thousands. Bonnie's Bus, Kim's group, the prevention of tobacco studies, the population studies. If everything gets vetted through the PRC, that means the cancer center is accountable for it. That's what the NCI wants to see. And one of the first things we did is we've worked with the IRB. There's an institutional policy that any cancer-related protocol has to go through the PRC for scientific merit and prioritization. We're not broke, and we're asking for advocacy. Can you get the patients on study? But if we do that process, that means it's been peer-reviewed within the cancer center that helps the IRB, and we can take credit for those points. And it's going to be wonderful when we write a core grant and you see thousands and thousands, and our eyes are going to go out. And that's great because we have a wonderful population program here, prevention program. So when my colleagues throw up their arm, why does it have to go through the PRC? It has to go through the PRC. No ifs, ands, or buts. That's what we're about to grow this cancer center. It's an outstanding opportunity for us. But these are very meaningful numbers. The trend is established. Look at these numbers. This is our bone marrow transplants program. We were down to 1 physician. And Dr. Bell and Dr. Abraham and I tinker on the unit. These numbers are growing. We would be up to, if we maintain this pace, I guess that projects to like 66 this next year. Only bone marrow transplant program in the state. Dr. Craig is an outstanding clinician. You're going to hear some announcements tonight. This program is poised. We have 2 young investigators joining us come July. Dr. Hamadani from Ohio State, very well versed in NCI trials. And another gal, Christy Stotler from Cleveland Clinic, benign and malignant hematology. We're getting Mike some infrastructure. These are the folks that we've recruited since 2008. I won't go in, you see the names, but more importantly, look at the institutions. University of North Carolina, Penn, the K-25 award, Adam Halaj, Pennsylvania University, came to the Cancer Center and helped him file his grant. We have him mentored in the program, in the COBRA, with Laura Gibson. Mike Rupert from UAB, NCI Center, the new Statler Chair. Stan Majewski, the Jefferson Laboratory. It's all outlined in some of the literature we've given you. Ohio State, Cleveland Clinic. We are attracting a different caliber of science and physician. This is wonderful. And what's not on this list, Susan Faulkner, well, yes, Susan's here in research administration, help us write grants for Virginia Tech. Jua Liu from the Karolinska Institute. Sarah Knox, did I miss Sarah on this list? Sarah Knox from the NIH. We have a wonderful start to recruitment. Wonderful start. And it starts feeding, and we're taking advantage of this. Here's some of our grants that have gone in the past year. Some don't win, some do win. The Coleman and Benedum grants were afforded the opportunity of Bonnie's Bus. We have a couple other, we got a pilot funding grant that we put together that Dan did just before he left that will help us during this time, since we're not going to be able through our foundation accounts to have as robust a pilot funding program. Another vital resource for a cancer center is to be able to have a pool of funds to support junior investigators. The Cancer Center also was the first recipient of a request by the Health Sciences Center, which is also a wonderful display of institutional commitment. They put out a request to bring multidisciplinary teams of investigators around a common theme. They had to have some grants to be able to compete for $100,000 of funds to lay the foundation for perhaps a successor PO1 grant, program project grant. And the Cancer Center investigators with John Barnett and Bing Hua were the first collaborative team to get access to that funding, and that award will be recompeted later this summer again for another one. We are just going gangbusters through the Stimulus Recovery Act, shared instrumentation. We're going to do our part. We've already written 2 shared instrument grants to get things out the door. We want to get a confocal microscope. We have another opportunity to write a grant. That goes in a little bit later. We talked about the construction grant. We're going to see if we can get this education. You know, again, remember my first rule. You can't get funded if you don't write a grant. And we're not delirious to think we're going to hit every one of these. But we're going to provide ourselves with the opportunity to get that type of funding. And this is just a list. I'm not going, you see all the different investigators in the Cancer Center and their national grants that they have. And this list is growing. He said we're about 3 million. The hardest part is what Dr. DeRochelle said. It's not the exact dollar amount. It's now demonstrating that we have interactions, that programs and investigators are sharing one another. And maybe the best thing I can share with you here, I was going to say it tonight, the Statler gift enabled the recruitment of Mike Rupert. He started in, when did you get here, Mike? December 1. It is April 18, because tomorrow's my mother's birthday, April 19, right? He and Laura Gibson have just authored a co-investigator grant. You know how important that is? That's a new concept that we're trying to get across to everybody in the Cancer Center. And to have 2 of our leading scientists be able, in less than 4 months, for a new investigator to be here to put pen to paper on a co-investigator grant, that's what we have to sell to our colleagues. Even if it doesn't get funded, something good is going to happen to that. And you set the pace, you set an example for your colleagues to begin to start connecting the dots. It's just so important for a cancer center. These are the pilot awards we gave last year. 2 of these awards led to funding, so we were good in our review. One of the folks, unfortunately, is going to be leaving the institution, but we'll continue to collaborate with Kim Horn. Last series of slides. This is the cancer problem. This was the opportunity when you look at the numbers. Charleston is the capital, or the population, well, obviously it's the capital, but it's the population center of the state. 17% of DRGs, or cancer diagnostic related groups, come from Charleston. Morgantown is 10%. If you look at the Eastern Panhandle, that's another 3%. So Morgantown theoretically has access to the second market share. And then you see all the rest, right? Look at out of state, 12%. Did I say that right? 10%. Actually, it might vary between 10 and 12%. I think, right, Gary? He's not. It's close enough. The beauty of that number, this is a weirdly shaped state. And outside of Charleston, everybody lives around the borders. So guess what? People are more likely to go to Pennsylvania, Ohio, North Carolina. You get the picture, right? We're not competing with other folks. We're competing with out of state. That was the premise to try to build this statewide network. This was very powerful data when I was looking at this to try to grow this cancer center. Very powerful. And again, the importance of trying to build partnerships. As I said, small state, all the health problems. We have lots of opportunities to partner, and we're going to try to really make sure this happens. And to Dr. Abraham's credit, before we got down here, Dr. Abraham had asked, I've been networking with physicians. He has an unbelievable reputation amongst his colleagues throughout this state. It's really unparalleled. Second day on the job, James took us down to Roanoke. First time ever medical oncologists got together in this state for the first time. 80% of the practices were represented, and it has really moved from there. We've established a society. We're recognized by ASCO, the national agency. We're hopeful to build this clinical trials network. And what we really want to do is develop a separate 5013C. Here's the Statler gift. You know the elements by now. Here's the bus. This is our laboratory. Basically, this is an extension of our laboratory. And we have a lot of different surveys. Our group has already begun some pilot testing with women on the bus. We've had 16 women go through the bus in Blacksville. Unbelievable number. And Amy and our gang and Gary, wonderful opportunity. Lots of our population researchers are engaged in this program to see how we can reach out. And if we do this right, all those research projects have been vetted through the PRC. Suresh was throwing up his hand. Oh my God, why do I have to send it here? It's been vetted at the Cancer Center. It's been viewed. So before long, every person that registers through Bonnie's bus goes into that non-therapeutic database as an accrual. Those are just powerful numbers for us that we can demonstrate in a core grant. Here's our network of states. We had the good fortune of getting some grants from Komen and Benedum to provide research nurse support. In our ultimate strategy, we've invited ourselves to the University of New Mexico, which is now on a core grant renewal. New Mexico doesn't have near the cancer problem we have. They have an NCI designated center, and they're going in for their first core grant renewal 5 years later. They have set up a 5013C clinical trials network. A couple places are doing that. That's the success for our cancer center, because guess what? We can it breaks down barriers, gets rid of silos. We can all work together. We can all fundraise separately. We're already making some discussions with the state legislature. So this next 2 years, we want to be able to show that the money that we're giving them through the Benedum Foundation, the Komen Foundation, is enabling getting patients on study. And not only that, the Cancer Center has just made a commitment and an investment to invest in a new database. We're purchasing the Encore database platform. And the idea is that you can register patients all over the state directly in our database. You can get an electronic consent form that can be uploaded. We want to centralize this in a 5013C. We can raise money, and the hope is you can get a state line item in the budget, say $300,000, $400,000, that drives this network. And guess what? We make access to trials to patients throughout this state, not just here in Morgantown. It's a wonderful opportunity. And it's going to have its ups and downs, right, James? We're going to get it done. But this is another wonderful opportunity that we can do here at this cancer center, is if we raise the level of care throughout the state, this hospital, this university will be the beneficiaries of that, because there's going to be a trickle effect. We are going to attract patients here to the cancer center, no matter what. And then you've seen the new facility. This was back, that could be what, December? It went up pretty quick after this phase. It's amazing how it got framed. Here's our new facility that we've dedicated, we've all been through. These are the numbers. We've basically doubled our research space and clinical care space for cancer. It's really an extraordinary commitment for an institution our size. We're going to write the CO6 grant to fill out the other shell space items that we've talked about. Our targeted renovation completion date is probably now about mid-June. You did not probably see the old space where patients were being seen, that we're doing all the renovation of the old space for the multidisciplinary clinics, extra examining rooms, and so forth, and a big, conference room. The renovated construction is 17,000 square feet behind the new building. And this is, again, the extraordinary commitment of the institution and the hospital and Bruce McClymonds, $22 million to finish this. What's also not on this slide, WVU It's the bane of our existence, but it has to happen. We have an electronic medical record. It must happen. $90 million investment by this institution. That is huge, the institution and the practice plan. These are all ingredients that will count. These are all ingredients that get written in an NCI grant. And I won't go through all this. You've walked through the expansion. You've seen what we have. And my last slide, well, I have 2 more slides. We're going to continue to support CCSG eligible funding. We're going to work with the Health Sciences Center, School of Medicine, hospital leadership. And again, I come back to that. The hospital, the practice plan, the School of Medicine, everybody is solidly behind growing this cancer center. I know we have challenges. We don't have all the funds that we would like to have, but we're taking advantage of opportunities, and we're going to get things done. We're moving forward. We're going to try to develop new relationships with Marshall. They have a COBRA grant. We're going to have a retreat this summer. We're going to invite Marshall. They don't have the breadth of the scientific or clinical expertise, but they do have an obesity initiative that has some basic science, that might be an entree for us to see if we can partner with them to build a scientific program and collaborate. They have a wonderful DNA core facility, genomic core facility that we provide. Many of our scientists are already collaborating and are having advantages of that because of a major investment Marshall has made in that technology. If we can get these pieces together, remember the whole is greater than the sum of its parts. Marshall, we think, could be a very prime opportunity for us to collaborate as well and continue to build partnerships, not only in the Health Sciences Center, this entire university and regionally. We must develop our lung cancer program as a health disparity program to another level. We're trying to work with folks, and we're capitalizing on opportunities through the American Recovery Act. So this was the slide of summary, why seek an NCI designation. You begin to see how the Cancer Center is trying to connect the dots and build things. And I hope I've convinced you that we are well on our way. It's not going to happen soon, but we are well on our way. Things are getting aligned for us to write a grant. And at last year's retreat, a couple days before our retreat, I was reading the New York Times, and this is when gas, it's still awful, right? But gas was like $4 a gallon, pushing $4.20 or something like that. And all these the inventory, and nobody's buying these SUVs and this, and that. And the new CEO of Ford was saying, with restructuring, you create one Ford, one team, one plan, one goal. And I quoted this exactly as I'm speaking at our scientific retreat last summer. And our mantra is one MBRC, one team, one plan, one goal. We want to get an NCI grant here for this institution and for the state of West Virginia. It deserves it. It deserves it for the cancer problems that we have. And I cannot tell you, if I stand here before you almost 2 years on the job, that I would think we would be this far along. Before I got here, I would have said you're absolutely crazy. So we're clearly, my colleagues and I, and the institutional vision to grow this cancer center is moving forward. We'll have lots of challenges. Our biggest challenge is going to get my scientists and colleagues, and Laura Gibson and Mike Rupert are leading the way to put pen to paper together, write joint papers, facilitate interactions. And I'm hopeful you're seeing how we are reaching out to literally everybody on this campus, not just the Health Sciences Center. And that's the fun part of being a Cancer Center director. So that's your summary. We're going to have a great day. We have a blue and gold football game. And I know I'm going to the fashion show. We're going to have a great fashion show. And we're going to have a great evening.